Good morning. Good morning, everyone. I would like to welcome you to the first of my lecture series on feminine wellness. I am Dr. Annebelle D. Aherrera, the founder and director of the Aherrera Wellness Group, which was established to promote a better quality of life and liberating feeling of wellness through heightened self-awareness of the many intimate and personal issues that women experience in their life's journey. Through additional knowledge, education, and options for alternative treatments, it is hoped that women out there who suffer quietly and silently would seek help courageously and come out to seek consultations where and when possible. I take pride this morning in starting my first series on breast cancer awareness, a topic very close to my heart. I chose to wear pink. As you can see, even in my posters, I love pink, particularly this first series of mine, because pink signifies friendship, inner peace, harmony, and affection. And I will continue to choose to wear pink now that I am a strong supporter for those women out there battling their lives. Even my own youngest daughter, who is fighting for her life against breast cancer. And so this morning, my webinar will be, the purpose is for the following. Create awareness for you women and for you, my audience, to fully understand that breast cancer is a disease to reckon with. It is a long, tedious, secondly, it is my hope that after this lecture series, that I may empower all the women to fully understand that you have control of your body. It is only you who can control your life. And so as I begin my lecture series, for today, I have 3 take-home messages. I will always emphasize these as I go along. 1, for breast cancer, no one is spared. 2, early detection, early prevention, early detection will save your life. And 3, it is only you who can make it happen. So I shall start, and I hope this will be a fruitful morning for all of you. Okay, let us start with some statistics. Breast cancer is one of the top causes of deaths amongst Filipinas. 1 in 13 Filipinas will develop breast cancer in her lifetime. It is rare in the ages 20 or 30s. with less than 5% of all cancers. Most common cancer for women in this age group. The young, when diagnosed with breast cancer, is more likely to be more aggressive or metastatic at the diagnosis. With 49 million females in our country, these numbers may even increase. And the #1 risk factor for breast cancer is our gender, that being a woman. And therefore, you and I are equally at risk, and no one is spared. So the risk factors, the main risk factors for breast cancer are being a woman and getting older. The incidence increases with age, and most common in females over the age of 50. Family history. Women with breast cancer with a history of breast cancer increases double with a first-degree relative, mother, sister, and daughter. Genetically, interestingly, white women are more likely to develop breast cancer than the Black, Hispanic, and Asian women. And for genetics, it is known that 5 to 10% of breast cancers are caused by inherited gene mutation like the BRCA1 and BRCA2. At this point, I'd like to emphasize that women with these risk factors that do not change may not even develop. Versa, those women, even without these risk factors, can get breast cancer. Breast cancer is also they also develop from the contributory factors of our lifestyle, and things that we do can also increase our risk for breast cancer. And these are the risks that we can actually change by staying healthy. #1, maintain a healthy weight. Women who are obese or overweight have a higher risk of getting breast cancer than those with normal weights. Now, how do we do this? It is best to measure our body mass index, and this is calculated using the BMI with weight in kilograms divided by the square of height in meters. Your BMI is actually an indicator of the amount of body fat that you have. Interestingly, research shows that dietary fat should be 20% or less in order to gain meaningful protection against cancer, understanding fully that fat cells can make estrogen and can promote breast cancer. And even diets high in fat are associated with increasing breast density in mammograms, which makes interpretation even more difficult. What about unhealthy practices like alcohol? Breast cancer increases with more alcohol intake. So it is best to limit. Smoking is also known to increase the risk for breast cancer with exposures to chemicals that can cause carcinogens. It is also known that women not being physically active have a higher risk of getting breast cancer, and therefore the recommendation is to exercise at least 3 times a week, at least 30 minutes a day. Okay? And it is found to lower breast cancer by 40%. And we cannot emphasize the fact that we all need to have a lifestyle check by keeping a balanced diet with rich in protein, veggies, fruits, and whole grain. It is known that fiber provides protection against breast cancer because it has a certain mechanism that decreases the amount of estrogen in the body. So, diet rich in fiber provides a protection against breast cancer. And so, with all these risk factors that I've mentioned, risk factors that you cannot change, and these risk factors that you can actually change by staying healthy, I am sure there are many of you out there who still have questions or doubts about breast cancer. Let's call them myths. And then I can actually answer with the fact. Myth number 1. Breast cancer is a death sentence. Many of us would be fearful. Just the thought of breast cancer, we think we're going to be dead soon. The fact remains that early detection saves lives and saves breasts. 2, most breast cancer runs in the family. Take note, only 5 to 10% of breast cancers are thought to be hereditary. 3, breast cancer occurs only in older women. While older women are more vulnerable, we see this in women older than 50, breast cancer can still be diagnosed at a very early age. 4th, bigger breasts have higher chance of getting breast cancers. There is no proven research on this. However, breast sizes have equal chance of developing breast carcinoma. Wearing tight bras, sports bra, wearing underwire bras, sleeping face down, trauma to the breasts, no proven effect. Next, regular mammograms prevent breast cancer. How many women out there fear to have their mammograms? Because it's painful, it's uncomfortable. But we need to understand that mammograms do not prevent breast cancer. In fact, it saves lives and breasts by finding breast cancer as early as possible, especially when it's most treatable. All breast lumps are cancerous? Relax. 9 out of 10 breast lumps are not cancerous. If, however, a persistent lump or you notice any change in your breasts, it is time to see your doctor for a clinical breast exam. But you may ask me, how will I know if I have a breast lump? How will I know if there are any changes in my breasts? Have you ever seen your breasts? Therefore, all of you out there, it's time to think pink. It's time to give yourself pink time. 5 to 10 minutes of your time is important for the first breast screening of your life. And that is breast self-examination. So you need to take time, think pink, think 5 to 10 minutes of your precious time. You spend so much time looking at yourself in the mirror. You see your face, you see a blemish, you see a pimple, you see a wrinkle, or you even see crow's feet on your eyes. But listen, do you actually know how your breasts look? So the first step is to know your breasts. While standing or sitting in front of a mirror with your clothes removed, it is time to look for differences between your breasts. This is the visualization aspect of your breast self-examination. Look, what do you see? Is there symmetry? Are they alike? In size? In contour? Do you notice any difference? Watch out for visible lumps or thickening, or dimpling or indentations that look like this. Have you noticed any redness? Or even scaliness? Still knowing your breasts and thinking pink, take note of changes in the skin that appear abnormal, or changes in the nipple that may be inverted in or pulled in. So that is still part of your first visual aspect. To continue, still thinking pink, this is only probably just 2 minutes of this self-examination process. Looking again at those same changes that you've noticed in your breasts, this time, put your hands on your hips while squeezing your elbows forward, and notice and watch out for lumps that might appear. Keep your hands on your hips, swivel from side to side, catching possible changes from different angles. Watch out for abnormalities in terms of the contour. And now with your arms lifted above your head, watch out for puckering, dimpling of the skin, as this means that there is the presence of mass that will pull in the skin when arms are raised. Next, so that's only 1 minute. Another would be your feel part of your breast examination. Now, with you lying down, with the pillow propped up on your head and an arm resting behind it, with using your 3 fingers, namely your index, middle, and ring finger, this time press down on your breasts using any of these 3 patterns. The up and down movement, okay, from the top of your breast to the bottom of your breast mound, feeling for any palpable changes or masses. Second, you can also try circular motions. The first around the biggest part of your breast mound, and then coming closer to a smaller circular motion. And the third would be towards the nipple area, where you can actually see changes of the nipple in terms of inversion or possible any change of redness or any form of discharge or fluid. Now that you're done with that manual examination of the breast, it is time now to examine the areas surrounding the breast. So, again, lying down, using the 3 middle fingers and applying 3 levels of pressure in a circular motion or in an up-down pattern. It is time now to check the lower part of the breast, traveling up to the areas under your arm, like in this picture, and watch out for any swelling in this area Feel for any pea-sized swelling or corn kernel size or marble size or anything that may feel different. So that's just 1 minute again. Next, squeeze the nipple of each breast gently between your thumb and your index fingers to watch out for any discharge or fluid. So, perform the test at same time each month. Again, 2 steps. Visual inspection, watching out for changes in your skin texture, atypical fullness or puckering, retraction of or indentation of your nipple, watching out for any discharge from the nipple. That is your visual inspection. And your manual inspection, watching out for or feeling any palpable mass. So for women out there who are still menstruating, please do examine your breasts 7 to 10 days after the first day of your menstrual cycle. And for those women postmenopausal out there, do examine any time of the month, but making sure it is the same time each month. So my dear friends, know your breasts because you are the gatekeeper. So remember, no one is spared from breast cancer. Early detection saves lives. All women 40 and older should get an annual mammogram. Remind your mother, your sister, your daughter to schedule a mammogram because 98% of breast cancer patients survive when diagnosed early. And remember that 85% of women with breast cancer have no family history or risk factors. Understand that it's time for pink time for yourself. Self-breast examination is important because breast cancer screening starts with you. Save your life and save your breast. So you may ask, what causes breast cancer? Actually, I don't know the answer. No one knows what causes breast cancer. But definitely, you didn't cause it. It's not your fault. It is important to understand that breast cancer is not just one disease. It is a group of diseases that are similar because it involves the breast tissue. And therefore, if there's a story of your aunt, your grandmother, your friend, it does not necessarily apply to you. The term breast cancer applies to a group of diseases that are similar because they involve the breast tissue. And this is why it is such an intricate and complex disease because of its anatomy. The breasts are a glandular, it is a gland and an organ that is actually found, of course, it's found on our chest, okay? Understanding here, this is your front view and this is your side view. Take note, I will try to explain this in detail. Your breast is made up of milk ducts. Milk ducts. It is actually made up of a network of 15 to 20 mammary ducts that lead to the lobules, okay, which actually contain cells that secrete milk. The lobules are the site of milk production, and the lobules are stimulated by estrogen and progesterone, which are your ovarian hormones. Now, these milk ducts connect to the nipple, which is actually the raised part of your areola, which is the ring of the darker breast skin. Okay. Your breasts are actually include your fat, which are interspersed in between. You will have your blood vessels, and your breast tissue is supported by your muscle and your ribs. Now, interestingly, the breasts have what we call lymphatics. These are depicted in these green lines. Take note, lymph is a clear fluid that gives water, food, nutrition to the breast. And it also protects the breast from any germ. Lymph, take note, drains from the breast tissue into the lymph vessels that travels into the lymph nodes near your armpits. And these nodes near the armpits are called your axillary lymph nodes. This is why it is important for you, all of you out there, to understand that it is this lymphatic drainage that will affect your staging, the disease that you will have when you are diagnosed with breast cancer. So, again, this is a better picture. You have your nipple, your ducts, which look like spoke of a wheel. Then you have your lobules that look like clusters of grapes. Then you have your fatty tissue, your lymph nodes, and your muscle. Just remember these physical and these anatomical structures when it comes to your breast anatomy, because all of these will be affected when you have this disease. So, where does breast cancer start? It starts in the cells of the breast, where normal cells change, grow, reproduce more than they should. Almost all breast cancers are carcinomas that start in the cells that line the inner or the outer surfaces of the body. There are different types of breast cancer, and this is where I want you to understand. Owing to the complexity of the breast anatomy, the biggest difference of the differences of all these types of breast cancer is where actually the tumor starts. And there is more than one type of breast cancer. Ductal breast cancer starts in the cells that line the milk ducts. These are the thin tubes that carry milk from the lobules of the breast to the nipple. Ductal breast carcinoma is the most common type of breast. Lobular breast cancer, on the other hand, starts in the lobules or the milk glands of the breast, the site of milk production. Again, more than one type of breast carcinoma. Paget's disease starts in the nipple. Inflammatory breast cancer involves the skin of the breast, where there is no evidence of a lump at all. It looks like a peel of an orange, or it is known as a peau d'orange. And this is due to the fact that the cancer cells are blocking the lymphatic vessels in the skin and breast tissue, causing pain. And because it has reached your lymphatic vessels, it spreads quickly. Which brings us to the next question then. What happens whether the cancer now has spread outside its original location? So we have two. We call these the non-invasive or the in situ cancer, where the cancer cells have not moved beyond the duct or the lobe in which it started. So in this picture, you will see that the cancers, this is your normal duct, those are the normal cells, but with a ductal carcinoma in situ, the abnormal cells are still contained within the duct. And that's why it is called, an early form of breast cancer, it's called ductal carcinoma in situ, and the most common form of non-invasive breast cancer. Invasive, on the other hand, the cancer cells now have grown beyond its original location into the surrounding normal breast tissue. It could be the fat, it could be the lobules, muscle, lymph nodes. It starts from the milk ducts or the milk glands into the breast tissue or the nearby lymph nodes. It now has a potential to spread to the other parts of the body. And invasive breast cancer is the most common form of breast cancer. How does breast cancer spread? First, let's do some terms that need to be understood. Primary tumor. Over time, remember that cancer cells form a mass that is called a primary tumor. I'd like to emphasize that breast cancer has to divide 30 times before it can be felt. So with most breast cancers, each division takes 1 to 2 months. So by the time you can even feel a cancerous lump, the cancer has been in your body for 2 to 5 years. So again, early detection. Invasive. Cancer cells can grow into surrounding tissues. Invasive breast cancer is again breast cancer that has spread again from your milk ducts or lobules into the breast tissue or nearby lymph nodes. Metastatic or metastasis, when the cancer cells now have spread and form tumors in other parts of the body, where the cancer cells break away from the first primary tumor and travel now through the blood or lymph vessels to distant sites. Once in other sites, the cancer cells may form secondary tumors. And if it has spread to a nearby body part, such as your axillary lymph nodes, it is called a metastasis. Cancer that has spread to a body part far from the primary tumor is called a distant metastasis. It is important to understand that breast cancer can metastasize to the bones, to the lungs, liver, spine, or brain. Remember, breast cancer that has metastasized to other parts of the body is still called breast cancer. So, just for you not to get lost and to take home all these messages and absorb what I'm saying, remember, inside the breast, you have your lobules, the site of milk production. The milk ducts carry the milk from the lobules to the nipple. Your breasts have fat, blood, lymph vessels, ligaments, and connective tissue. Your breast cancer often starts in the ducts or the lobules and then spreads into the surrounding tissue. Non-invasive breast cancer is only found in the ducts or the lobules, while invasive breast cancer has grown outside the ducts or the lobules into the surrounding tissue and may spread through lymph or blood to lymph nodes or other parts of the body. And metastatic breast cancer has spread to distant sites in the body. Interestingly, anyone can have breast cancer, including men. Although there are some differences between men and women, the treatment may be similar. And therefore, what happens if in your self-breast examination, you find the breast mass? Is this you? Or is this you? All I can say is you do not need to panic. If you think you feel a lump in your breast, remember, most women have lumps or lumpy areas in their breast, particularly when it's near their menstrual cycle. And most breast lumps turn out to be benign. Remember what I said, 9 out of 10 breast lumps are not cancerous. There are possible causes of non-cancerous breast lumps, including hormonal changes. My suggestion is if you find any change or any lump in your breast during your breast examination, observe for 1 full menstrual cycle to see if the breast lumps get bigger or become more prominent in changes in colors or in skin or in contour. If you are menstruating, you may want to wait until after your period to examine your breasts, as the lumps or these changes may disappear. If, however, they are still present, seek consultation and set a doctor's appointment. Take with you your medical, your family, your fertility, and your lifestyle history. Your doctor will perform a physical examination similar to what you've been doing, your breast self-examination. It is important for the doctor to feel the location, the consistency, the extent, and the presence or absence of the nodes. The doctor will require breast imaging tests and possible genetic tests, and understand fully that a tissue biopsy may be needed, as this is the first step in the diagnosis and the treatment. Imaging and scans, mammograms, is the first screening breast imaging test. In mammograms, each breast is compressed horizontally. As you can see in this picture, the breast is placed between 2 plastic plates and they're briefly compressed to flatten the breast tissue. You will also notice here, now there are just radiographic pictures because these are made using X-rays combined with computer to make detailed pictures. Here you can see a normal mammogram, then presence of cancer, or a benign cyst that is not cancerous, or calcium deposits. Mammograms are actually requested and done to check if there is more than one tumor and the size of the same breast or tumors in the opposite breast. This is used to plan your treatment. Second, sonomammograms or ultrasound of the breasts. This uses high energy sound wave to form pictures of the inside of the body. This is actually good at showing areas of cancer that are near the surface of the body. So here you see your lymph nodes, your mammary ducts, the glands, the lobules, the ducts, and your ultrasound probe. Remember that the sonomammograms is actually the first screening breast imaging test for patients under the age 30. It is oftentimes used to guide a biopsy. Breast MRI actually uses radio waves and powerful magnets to take pictures of the inside of the body. It does not require x-rays. However, contrasts may be used. Your MRI has proven valuable in detecting and staging breast cancer. If needed, a breast MRI would be in addition to a mammogram, especially if you want to detect if, let's say, there are visible lesions already on mammogram, you would like to see if there is still enhancement of these possible lesions. A breast MRI should always be performed and interpreted by an expert breast imaging team working together with a multidisciplinary treatment team. CT scan. This uses X-rays and computer technology to take pictures of the inside of the breast. It takes many X-rays of the same body part from the different angles. And normally patients with breast cancer or with diagnosis for possible breast cancer, normally a chest CT of the chest and abdomen are requested to determine if there is breast cancer spread. Bone scans. Remembering that breast cancer can spread to bones. An imaging test such as the bone scan to show these. And this may be used also to monitor treatment, where the entire skeleton will be checked. In a bone scan, you use a radiotracer where the substance is released from small amounts of radiation to make pictures of the inside areas of your bone that may appear and seen as damaging or abnormal. Areas of bone damage will be seen where the radiotracers are actually highlighted as bright spots on the pictures. PET scan is a positron emission tomography that uses a radioactive drug called a tracer that is actually put inside your body to see how the cancer is growing and where it actually is in the body. However, cancer cells do show as bright spots on the PET scans, but there are some points where bright spots are not necessarily cancerous. So sometimes this PET scan is best used with a PET CT scan as a combination. Genetic tests, family history. Now this is an optional test, but it is best for all of you to understand that genetics, as I have mentioned, 5 to 10% of breast cancers are noted to be hereditary. Genetics can increase the risk of breast cancer. Tests may be offered or ordered to determine if your cancer is due to an inherited genetic mutation. And this will help tremendously in the treatment decision. Interestingly, everyone has genes called BRCA1 and BRCA2. These normal BRCA genes help to prevent tumor growth. They actually help fix damaged cells and help cells grow normally. And blood, when taken, can determine if you have BRCA1 and BRCA2 mutations that put you at risk for more than one type of cancer. Since mutations of these genes can increase the risk of breast, ovarian, prostate, colorectal, or melanoma skin cancer. Mutated BRCA genes can also affect how well some treatments work. Your doctor might choose a treatment that is known to work better for your mutation. So, now that you already have all these imaging tests, we need to confirm a diagnosis or make a diagnosis. And so a breast tissue biopsy is required. Remember that not all breast cancer are treated alike. And your doctor will actually do this tissue biopsy and have it tested. And so this tissue biopsy will actually remove a sample of your tissue or fluid and test it for any of, and give you a certain report. Now, there are different types of biopsies. Now, some of these biopsies are guided using imaging, such as your ultrasound or your CT scans. Remember, the biopsy is done on your primary or main tumor. Other tumors in different areas may, however, be biopsied. And this could be from the breast or your lymph nodes or both. Now, some of these biopsies are a fine needle aspiration biopsy, wherein you use a thin needle, as you can see here, removing a sample of the tissue or fluid attached to a syringe. This is guided with breast imaging tests. The core needle biopsy, here you will see, yes, a core needle biopsy, removing several tissue samples with a wide hollow needle, and sometimes a vacuum is used to remove a larger sample. So if this is your lump, here goes your needle, okay, and that is your tissue sample. The needle is guided again with imaging. And after this is done, one or more clips are placed in the breast, the area of question during a biopsy. And because these clips are small and made of metal, they're actually used, or they become the site for future treatments and imaging. The clips stay in place and may be in your body for a period of time. Others would call an incisional biopsy, where a small amount of tissue is removed through a cut in the skin or the body. Next is an excisional biopsy, where it removes the entire suspected area plus some surrounding normal tissue. This is a standard procedure for lumps, most likely presumably benign, that are slightly smaller than an inch or so in diameter. Now that you have your tissue biopsy, what else happens when you send out these tissue to the pathology? Okay. I would like to emphasize the sentinel node biopsy. Okay. Must remember that your sentinel node is the first lymph node to which cancer cells are most likely to spread from your primary tumor. As seen in this picture, this is the area of suspicion, the sentinel node, okay, to find these sentinel nodes, okay. A radioactive material, a blue dye, is injected into the body near the breasts, where they travel through the lymphatics in the breast to the lymph nodes. Now, this actually helps the surgeon find these sentinel lymph nodes. And when they are found, they are tested. Your sentinel lymph nodes can be more than one. And sentinel lymph node biopsy may be done with your surgery, lumpectomy, with surgery to remove a lump, or mastectomy to determine if any of these cancer cells have traveled to the lymph nodes. There is also the axillary lymph node biopsy, okay, where again your lymph, remember, drains from the breast into your nearby areas, and when palpable, a sample of your lymph node in your armpit is biopsied with a needle. This is again to determine if abnormal lymph nodes are seen on imaging tests containing cancer cells. An ultrasound-guided fine needle or core biopsy will be used. If cancer is found, this is called node positive. So now that you have your tissue biopsy, what does the pathologist do? There are tumor tests, tests that are done on the tumor itself. There is a test known as the breast panel. This determines the two types of hormone receptors that are present in the tumor that you have submitted, okay? Particularly your estrogen and your progesterone receptors that are produced, your estrogen and progesterone hormones that are produced from the ovaries and carried throughout the body. Remember that these hormones, as you can see in this picture, attached to the receptors, the protein receptors that are found, okay, particularly inside the breast cells, okay? And so with these hormones attaching to these receptors, we can determine inside the breast if these receptors are actually loaded with these hormones and can cause cancer to grow. If these are present, these receptors are now the target, okay, using endocrine or hormonal therapy as part of your treatment. Now, to determine this breast panel of your hormone receptors, they use a certain special staining or the histochemistry staining. It's a special staining process that involves adding additional chemical marker to these cells. So a hormone receptor positive means that you have estrogen or progesterone hormone receptors in at least 1 out of every 100 cancer cells present. And this makes your breast cancers hormone positive. And there are two types of hormone positive, receptor positive cells. Estrogen receptor positive, where the cancer cells need estrogen to grow. These cells will only stop growing or die with treatment to block estrogen. Progesterone receptor positive are cancer cells that need progesterone again to grow, and these cells will stop growing with treatment to block progesterone. On the other hand, hormone receptor negative are breast cancer cells do not have either estrogen or progesterone hormone receptors, and therefore these hormone negative cancers often grow faster than hormone positive receptors. There are two types. Your estrogen receptor negative, ER negative, where your cancer cells do not have, again, your estrogen receptor, but these cancer cells do not need estrogen to grow and may continue to grow despite treatment to block estrogen. The same with your progesterone receptor negative. Cancer cells do not need progesterone to grow, but may continue to grow despite treatment to block progesterone. There is another tumor test that is done on your tumor biopsy. This is the HER, Human Epidermal Growth Factor. They determine your status. It is a protein found on the surface of breast cells, and this is normally found on your normal breast cells. And when the amounts are high, when the receptor, again, the amounts are high, this causes the cells to grow and divide. And too much of this protein is produced, and therefore too much protein, too much receptors. The tumor now is considered HER2 positive. When breast cancers have too many HER2 genes or receptors, this is called HER2 positive, HER2 positive. And this is done by using a biopsy sample. Pathologists pay attention closely to this because there are specific targeted drugs available for HER2 receptor positive cells. Now, apart from the tumor tests that are done by pathologists, there are, however, oncotype or genetic tests on the tumor itself. While these are available in our country, this may be a bit expensive, but suffice to know what these are. They take a piece of the patient's tumor. It actually estimates the likelihood of a recurrence after initial surgery or if further treatment is given. Your oncotype tests provide guidance on whether or not chemotherapy should be recommended. So this talks about recurrence, it talks about chemotherapy. For patients with a low risk of recurrence score, chemotherapy may be avoided. For patients with a high risk of recurrence, chemotherapy is likely. Remember that each of these tests is somewhat different in the population that can actually use them. It could be interpreted differently in the young, in the middle age, and in the older age. First, we have available MammaPrint, okay, which can be used in patients with an early stage, 1 or 2, or invasive breast cancer with a tumor size under 5 centimeters that is either ER positive or ER negative. The results will only show either you're a low risk or a high risk. Oncogenic or Oncotype DX tests, on the other hand, okay, the Oncotype DX are actually the tests to determine if for early stage breast cancers, particularly stage 1 and 2, that are node negative, ER positive, and invasive, okay? These tests will produce a recurrence score of 0 and 100. The higher the score, the greater is the risk of recurrence. So a woman with a score of 10 or lower can forego chemotherapy and can take endocrine therapy only because of the presence of your ER positive. Because the patient is considered low risk, forego chemotherapy. Women, on the other hand, with a score of 26 and above, as you can see here, especially in women over 50 years of age, okay, if you were to look at the left side of your screen, women with a score of 26 will have a higher benefit from chemotherapy in addition to endocrine therapy because they are at high risk. Now, the question lies now in the intermediate range, okay? Or those between 20 or 10 to 25, okay? There are evolving studies now on other systemic treatment options other than chemotherapy for those in the intermediate range. Again, as I have said, it would be dependent on the population used, as these will show us a specific guidance on women under the age of 50, but for those under the age of 50, there are evolving studies to show the different population age groups based on the Taylor trial results, providing this information on what to do about those women in the intermediate age. So you already have your biopsy, okay? It has already undergone the tumor test by the pathologist, and you are awaiting possibly for your oncogenic tests for the possible decision regarding your recurrence, possibility of recurrence, or the use or treatment with chemotherapy. Now that you have your biopsy report, what should you observe and what should you know? One, it should describe the gross or the outer features of your tumor, the color, the size of the sample, and the part of the breast from which the tissue came from. Pathology, it will tell you where the cancer began, whether it was contained or it had invaded. Is it a ductal or a lobular? Is it in situ or is it invasive? 3, the size. How big is the tumor in millimeters or centimeters? Location. Where on the breast was the tumor located? Histologic grade. This is important. Rating is based on how the tumor cells are fast growing and dividing. The higher the number, the faster the cells are dividing. So here we include the differentiation as whether the cancer cells look similar or unlike. Again, your pathology report should show the hormone receptor status, your breast panel, if you are estrogen or progesterone positive or negative, if you are HER2 positive or negative. Lymphovascular invasion. Remember your breast tissue, your breast anatomy. Put in mind visually that you have your lymphatic drainage. Has the cancer spread or entered the blood vessels or lymph channels in your breast as reported? Surgical margins. These are important because it will determine if the tumor that was removed have free or free cell margins. Area around the tumor is checked for any cancer cells. It tells you how close the cancer cells were to the edge of the tissue. The specimen that is removed by the surgeon will tell you if there are cancer cells at the tissue specimen or there are clear margins. A margin that is not clean or is not clear may need additional surgery. So it is important, even if the mass is presumably benign, it is still important to surgically mark this margin to determine if the patient will need additional surgery or not. Lymph nodes. The number of lymph nodes are when removed. How many were there? Were they positive or negative for cancer cells? Here you will also see if there is any indication on the pathologic report for any micrometastasis. And proliferation rate, cell division, it measures how aggressive your cancer growth is. The lower your Ki-65 rate, the slower your cancer divides or grows. It is reported as a percentage. Over 20% is deemed high. However, there is no conclusive evidence of your Ki-67 rate associated with survival. Don't panic. Not all reports contain this score. So, now, what is next? Now that you do have your report, now that you already have your biopsy report, you have your pathologic report, you have your imaging tests, what's next? Cancer staging. A cancer stage is a rating of the cancer based on all the results that were done. Staging is crucial to make treatment decisions. Cancer staging is often done twice. Clinical stage is the rating given before any treatment. It is based on the physical exam, biopsy, and your imaging tests. Pathologic stage or your surgical stage, however, is determined by examining the tissue that was removed during an operation. Breast cancer staging is based on the following. Remember TNM. Okay? I always ask you to think of pink. Now think of TNM. Do not panic when it comes to your cancer staging. Okay? Staging is a way of classifying the extent of your disease. TNM describes the different areas of their cancer growth. A number is specifically assigned for each of these letters to signify the size of the tumor, T, the number of lymph nodes involved, that's N, and whether the cancer has spread or metastasized, that is M. The higher the number, the larger the tumor, or the more the cancer has spread. These scores will be combined to assign a cancer a stage. A TN example might look like this: T1, N0, M0, or T1, N0, M0. Okay? Once the T and M numbers have been assigned, take note. This information, along with your tumors, breast panel, ER, PR, and HER2 status, as well as the grade, is used to determine the stage grouping. Okay. So I'll go back. T1, this is meaning to say that the tumor is more than 2 centimeters. NO means, N0 means no nodes, M0, no metastasis. So let's look at this. Clinical staging of lymph nodes is staging before. So you have your T, size of your main primary tumor, N, the presence of nodes if it has spread to their nearby regional lymph nodes, M, metastasis if cancer has spread to the different parts of the body or metastasized. Okay, this is actually based, okay, also on your pathology and your imaging results, test results. Number stages range from stage 1 to stage 4, with 4 being the most advanced. Stage 0 is non-invasive, or it is in situ. It is rated as stage 0, non-invasive breast cancer is rated as stage 0. This cancer is found again, if you remember, it's found only inside the ducts or the lobules and have not spread to any surrounding breast tissue, lymph nodes, or distant metastasized or distant sites. That's why it is N0, M0. For stage 1, 2, and 3, they are considered invasive breast cancer. However, stage 1 invasive breast cancer has the excellent survival rate. Okay. If you continue to pursue the recommended treatments given by your doctors, stage 2 will also be considered an early stage of breast cancer, and most of these tumors, stage 1, 2, and 3, are treatable. Okay. Stage 4 is metastatic. For most tumors, we consider stage 4 as a non-curable situation, wherein cancer has spread to distant sites. may also be found in the axillary lymph nodes, and it may even be stage 4 metastatic on its first diagnosis, as it can develop from early stages. Okay. So I just want to show you this. Cancer in the axillary nodes would be at this area. Cancer found in the internal mammary nodes right here near your sternum, in the middle of your chest. Infraclavicular nodes underneath your clavicle, okay, and then supraclavicle, clavicular nodes above your collarbone. So now that we already have an initial diagnosis, what is the next step? Your initial diagnosis will be based again on your clinical staging, based on your physical exam done by your surgeon, your imaging tests, your tissue biopsy report. And now we need to determine the extent of the cancer. What is the next step? At this juncture, you still need to continue thinking pink. But this time, you need to think pink if there was a diagnosis of breast cancer. Thinking pink this time is thinking cure cancer. Yes, you do have breast cancer, but there is no one breast cancer treatment. There is no one right way to treat it. And therefore, it is important to fully understand your pathology report, as this will tell you all your story. This will tell you your story. This will tell you what are the next steps for your treatment. What are the next steps for you to think cure cancer? Some typical choices involve local treatment like surgery and radiotherapy to remove all evidence of the original tumor. Systemic treatments like your chemotherapy and hormonal therapy are what you call the systemic treatment that treats your entire body with the intention of killing any microscopic cells that have left the original tumor and have traveled elsewhere. There is what we call the targeted therapies, okay, where it is directed at specific attributes of the tumor, okay? These target therapies only aimed at the cancer cells. Insist, once you have your diagnosis, your initial diagnosis, insist that your doctor explain why one treatment is being recommended over the other. Your doctor will tell you and recommend all these treatments depending on what is best for you based on your pathology report. But before that, for the young and for those with fertility issues, it is best to understand how all these treatments will affect your fertility. Remembering that everyone's journey is unique. It will be based on doctors' recommendations, personal preferences, and your information. Remember that not all cancers and treatments are the same. It is specific to each individual. There is no one size fits all, not a cookie cutter. The path that is chosen by someone else may not be right for you, and vice versa. And the order in which these treatments, okay, systemic or local, the steps in which this is taken to treat your cancer may also vary. While some women may have surgery at first, others may go straight to chemotherapy or other treatments. Okay. There are many treatment options. However, it is important to emphasize, not everyone will respond to the treatment in the same way. Some people will do better than expected. Others will do worse. Many factors play a role in how you will respond to each of these treatments. Let's go first to the local treatment. Surgery. It's still the main or the primary treatment for invasive breast cancer. Systemic therapy or radiation therapy might be used before surgery to shrink the tumor or reduce the amount of cancer called cancer burden. If preoperatively, there is treatment before surgery, of the systemic or radiation therapy, it is called neoadjuvant therapy. If the systemic treatment or radiation therapy is done post-operatively, it is called adjuvant therapy. What are the different surgical approach for invasive breast carcinoma? Lumpectomy is known as the breast conservation therapy, where only the tumor, along with the rim of extra tissue around the tumor, is taken. This is done to create a cancer-free surgical margin. The rest of the breast is left alone. This is normally done with a sentinel lymph node biopsy and in combination, followed by radiation therapy to kill any cancer cell that might have remained in the breast. This, however, may have more than one surgery and will determine the surgical or the pathologic staging. So lumpectomy in combination with radiation therapy is your first surgical treatment option. Mastectomy, on the other hand, is removal of the entire breast, typically including the nipple and the areola. In areas where, in a sample where the chest muscle is not removed, that is simply called simple mastectomy. At times when an option for breast reconstruction is considered, there is such a thing as the skin-sparing mastectomy. And this is done for reconstruction purposes that may be done either immediately after surgery or after completion of cancer treatment and done in stages. Before removing the breasts, may do a sentinel lymph node biopsy or an axillary lymph node dissection. It can be performed unilaterally or bilaterally. And sometimes when a BRCA1 or 2 mutation is reported, a prophylactic mastectomy on the healthy breast is performed. Again, in the mastectomy, it determines the final surgical or pathologic staging. At this juncture, I just want to emphasize, because you might ask, which is better, a lumpectomy or a mastectomy? Studies have shown that a lumpectomy plus radiation therapy in combination provides the same survival rate in a patient who has undergone mastectomy. Remember, mastectomy is removal of the entire breast. Lumpectomy is your breast conservation therapy, but must be in combination with your radiation therapy. So, your radiation therapy uses high energy radiation from X-rays, gamma rays to kill cancers and to shrink the tumors. It is given alone or before or after surgery to treat or slow the growth of the cancer. Okay? It is given during a certain period of time, typically at least 28 days, and only lasts a few minutes. It is sometimes given with certain systemic. Remember what I said, systemic is chemotherapy and hormone therapy. This radiation therapy is considered a local therapy because it is only emphasized on the area of the disease. There are the types of radiation therapy are whole breast radiation, wherein there is radiation to the whole breast, accelerated partial breast irradiation, where radiation is to the area where the tumor was removed, followed after lumpectomy. Lymph node radiation, the radiation is to the lymph node that is called the regional nodal radiation. So we talked about the treatment options using your local treatments. What about systemic treatments? Chemotherapy. It is a type of drug therapy to treat cancer. It kills the cancer cells that may have left the original tumor location and found elsewhere in the body. It targets fast-growing cells in the body, not only just cancer cells, and therefore may even affect the healthy cells and disrupt and affect the life cycle of these cells. And therefore, the common side effects are hair loss, numbness, nausea, but it actually depends on the type of chemotherapeutic drug that is used. Take note that chemotherapy may even be given as an adjuvant, that is, after initial surgery, or neoadjuvant before surgery, if it wants to shrink the tumor. Chemotherapy is given IV, but some intravenously, but some are given in a tablet form. It is given on a regular interval, typically once every 2 to 3 weeks, with a rest period. Examples of your chemotherapeutic drugs are adriamycin, taxotere, cytoxan. There are times when there's more than one drug may be used to treat invasive breast cancer. The cycles may vary in length depending on the drugs that are being used, and the number of treatment days per cycle and the number of cycles given varies. This is usually also given prior to radiation therapy. Hormones. Remember that hormones can cause breast cancer to grow. Hormones like your estrogen and progesterone stimulates your lobules, and these hormones come from your ovaries. So we pay attention to these hormones. Endocrine therapy will actually stop your body from making these hormones, or it will actually block what your hormones will do in your body. So this can actually slow the tumor growth, or it will shrink the tumor for a period of time. Endocrine therapy can be local, okay, or systemic. It is sometimes called hormone therapy. Remember that this is not the same as hormone replacement therapy, okay? That is only used for menopause. What are the 4 hormones that we might be targeting in our endocrine therapy? 1, your estrogen, and 2, your progesterone, mainly made by your ovaries. 3rd is your luteinizing hormone-releasing hormone that actually is made in the part of the brain called the hypothalamus. This actually stimulates the ovaries to make more estrogen and more progesterone. Next, we also want to target the androgen. These are your male hormones. These are made by the adrenal glands, the testicles, and a small portion by your ovaries. There are 5 main types of endocrine therapy. Ovarian ablation means permanently stopping the ovaries from making hormones. Okay, you ablate, okay, or surgically ablation. just totally removal of your ovaries. Next, you have ovarian suppression, where you temporarily stop the ovaries from making hormones. It is achieved by drugs called, again, your LHRH agonist. Remember, this is what is made in the brain, and it stimulates the ovaries to produce your estrogen and progesterone. What it does, it stops your LHRH from being made, and therefore it stops the ovaries from making hormones. Your LHRH agonists include Zoladex and Lupron, goserelin and leuprolide acetate. Aromatase inhibitors, okay. We need this to stop a hormone called androgen, so their male hormone, from changing into estrogen by an enzyme called aromatase. So your hormones that are specifically called aromatase inhibitors stops your androgen from changing into estrogen. This is a very popular drug for your postmenopausal women with breast cancer. They do not affect estrogen made by ovaries. Your non-steroidal aromatase inhibitors include anastrozole arimidex and letrozole femara. Anti-estrogens, okay, this is self-explanatory. It prevents the hormones estrogen from binding to the receptors. There are selective estrogen receptor modulators which block estrogen from attaching to hormone receptors, popularly known as tamoxifen and taromifen farestone. There are, however, new drugs that are selective estrogen receptor degraders that block and destroy estrogen receptors. We have Faslodex. Next, the last, hormones. There are hormones that may treat breast cancer when taken in higher dose. Not known how these hormones can stop breast cancer from growing. However, they may include ethinyl estradiol, fluomestrenone, and megestrol acetates. And so the goals for your hormone therapy, remember, is to reduce the amount of estrogen or progesterone in your body and to reduce the risk of breast cancer recurrence. Now we have targeted therapy. That's why it's called targeted. It only targets cancer cells and not the healthy cells. Thereby, the side effects are less. It is frequently described as a chemotherapy given through the vein, intravenously. The HER2 the HER2 protein, again, as I've said, are found in normal cell growth. The higher amounts of HER2 in breast cancer cells are called HER2 plus or HER2 positive. There is a HER2 targeted therapy known as the trastuzumab Herceptin, which is commonly used in these patients and has increased survival rates. This is usually given for 1 year. So with all these treatment options, your local treatment, surgery, radiation, systemic treatment, chemotherapy, hormone therapy, and now your targeted therapy. If you were young, or if you were just starting your family, or you're single and you're not sure if you're going to have children in the future, this becomes a major concern to many. For those who are diagnosed before having children, or may not have even finished building a family, or for those who have been trying to get pregnant and worry that breast cancer will delay your dreams of motherhood, or you may still remain single and wonder if you will be able to have children a number of years from now. These are valid thoughts and concerns. And therefore, we want to ask, if diagnosed with breast cancer and considering these treatment options, how do these affect fertility? Chemotherapy possibility of infertility because it damages and destroys the eggs. Remember, not all women diagnosed with breast cancer have chemotherapy. It would actually be depending on your age, your type, and the total of chemo drugs that contribute to the possibility of infertility. Hormonal endocrine therapy, tamoxifen, is not known to cause infertility. But remember, hormonal endocrine therapy is a long-standing treatment of anywhere from 5 to 10 years duration of your life. And therefore, with tamoxifen, you may interfere with your childbearing years due to the duration of this treatment. So when you are on tamoxifen, it may be a thought to consider a baby break from tamoxifen to try to conceive a child, then resume treatment after giving birth. Fortunately, surgery and radiation therapy, of course, do not affect fertility. Targeted therapy, Herceptin, is not known to affect fertility, but patients on targeted therapy are advised not to get pregnant while taking it and wait for at least 6 months before trying to conceive. And so, if, again, diagnosed with breast cancer in the young or in those still with questions on fertility, remember that time is of the essence in fertility preservation. You have to think and act quickly and choose your next steps wisely to preserve fertility. You want to avoid delaying breast cancer treatment, but you don't want to avoid, of course, delay. I don't want to delay your breast cancer treatment. So it's best to consult with a fertility specialist. So for those women out there with this issue, fertility preservation is for those women who want to protect their ability to have genetically related children in the future. These are women who have started their family and have not ended building their family, those who want to get pregnant, those who are single, those who are still considering pregnancy. So what are these preservation treatments? Embryo freezing. This is an option that you want to use, okay, for those who are already married, want to use sperm of your male partner, or for those who want a donor, okay, this is something that you can consider. These are what happens here, okay? You may have embryo freezing for those who are married, for those who are single but are afraid, don't have a partner, you may consider having a donor. So what do? You stimulate the ovaries. The method is just stimulating the ovaries to produce multiple eggs in a single cycle, harvest the eggs, and then the eggs are fertilized in vitro and then frozen and stored. This whole treatment will take 2 to 6 weeks. And if pregnancy is already considered, frozen embryos then are thawed and implanted in the uterus when ready. Now, what about those young women, those diagnosed at a very young age? Or what about those single women out there who do not have partners and are afraid of their future? Maybe you would want to consider egg freezing. Women who do not have a male partner or do not want to use donated sperm may choose to freeze eggs over embryos. The same treatment is done. Stimulate the ovaries to produce multiple eggs in a single cycle. Harvest the eggs, freeze them and store them. Takes 2 to 6 weeks for this whole cycle treatment. And when pregnancy is considered, again, the frozen embryos are thawed and fertilized with sperm in vitro and then implanted in the uterus when ready. So now that we have already gone through the treatment options and even the fertility treatment options, okay, what happens to you, to those who are already going through this journey? Patients with breast cancer need a comprehensive and holistic approach to care that goes beyond physical treatment, that would include support and interventional processes, so related to the psychological or mental health of the patient. Number one, if you are diagnosed with breast cancer, you need to advocate for yourself. Ask all the possible questions that are in your mind. Make time. There is plenty of time to make decisions. There is no need to rush. You have to understand your story. Seek out second opinions. Gain understanding. Understand what is going on. Explore other options and explore other doctors' recommendations or treatment. Remember, this is your body and this is your health, and it is time for you to take charge of your health. Second, take in individual psychotherapies if it will help you feel better, help you go through the emotional or the questioning and all the pain that you may actually experience. Okay. Even group psychological treatments with others are important, particularly in women who also share the same predicament that you are in. This gives you a chance to share and receive emotional support and learn from other experiences of others. This is most effective, especially in groups that should be made up of women at similar stages of the disease, and especially led by psychologists or mental health or even social workers to help you in your breast cancer treatments. Whether it is aimed individually or group, it's still important to have support the mental health of our loved ones. With every breast cancer single day, the only effective strategy that I can think of for personal support is just simply being there. So, breast cancer overview. Invasive breast cancer is treatable. The goal of treatment is you remove the tumor, prevent or slow the spread of the cancer. Remember, think cure cancer. Local therapy focus on a certain area that includes surgery, ablation, and radiotherapy. Systemic therapy works throughout the body. Includes endocrine therapy, chemotherapy, and targeted therapy. Targeted therapies can block the ways cancer cells grow, divide, and move in the body. The treatment for invasive breast cancer is a combination of therapies. Those who want to have children in the future, seek fertility specialists before starting chemotherapy and or endocrine therapy to discuss the options. And so, remember everyone, no one is spared from the big C. Early detection is still key. It will save you all the pain, the anguish, and the anxiety of having breast cancer, as it is a long, tedious process and will even take a lifetime to get completely healed. We want to prevent late stages of this cancer. So enjoy life to the fullest. It is only you who can make this happen. For all you women out there, think pink. Think pink. Pink time means a minute for yourself. And for those with breast cancer, do not fear. Do not fear. God is in control. For you are no longer a slave to fear because you are a child of God. And whether you are a survivor or a warrior still in battle or a mere supporter, each one of us has our own journey. Each step that we take in our life's journey is a tiny step, a walk with uncertainty, at times a stride in confidence, and giant step, and at times just enjoying life's comfort. And as long as we believe that we are children of God, do not fear, for you are not alone. Always remember the footsteps in the sand, where you will see two sets of footsteps in your life's journey. And at times, in your most difficult and troublesome times, at times in your darkest hour, you may even think that you only have one footstep, one set of footsteps in the sand. That is because He carries us throughout our journey. So that every single waking day of your life, treat it as a lifetime in faith, love, strength, so that the hope, we all hope, like the sun, that as we journey towards it, we cast the shadow of our burden behind us. Thank you for listening in my new and my first breast cancer awareness lecture. Let us continue the fight in faith, love, strength, and hope. Thank you. Okay. I would like to know if there are any questions. I am more than willing to answer them. Okay, there is a question here. Can hormonal therapy be used as a preventive treatment or prior to discovery or development of breast cancer? If yes, under what conditions can hormonal therapy be used prior to developing breast cancer? Okay, so there's a question. Can hormonal therapy be used as preventive treatment or prior to discovery or development of breast cancer? Hormonal therapy is part and parcel of the treatment of breast cancer. It cannot be considered a preventive treatment. Okay. Preventive treatment, if you were to denote that, is preventive treatment means, okay, getting through your breast cancer screening, the best way to even get into breast cancer is to start your screening. Start your screening with your breast self-examination. That is the best. Next, hello doc, I have questions. Which is better, SERM or SERD? Okay. Next, I am currently on tamoxifen and considering disrupting it to be able to conceive. Are there studies relating to pregnancy increasing risk of breast cancer? For those with hormone-sensitive cancer history. Next, if one gets pregnant and suddenly gets cancer, is targeted chemotherapy available in the Philippines? Okay, let's do it one by one. Okay. Okay. Which is better, SERM or the SERD? Your medical oncologist would be the best expert and the best in the better position to determine which is best for you. Either of the two, because the goal of hormone therapy is to reduce and to block your estrogen production. And therefore, any of these, okay, would be acceptable. Now, your next question. I am currently on tamoxifen and considering disrupting it to be able to conceive. Are there studies relating to pregnancy increasing risk of breast cancer for those with hormone-sensitive cancer therapy? Okay. Now, you are on tamoxifen, and as I have mentioned, you can take a baby break after you have at least treated yourself with tamoxifen for about 2 to 3, maybe 2-3 years, and then you can actually try to get pregnant. Now, is there a risk of breast cancer for those with hormone-sensitive cancer history? Very hard to answer because studies have shown there are minimal especially the risks are actually decreased if your hormone therapy includes an ovarian suppression agent, like your Zoladex or your Lupron, together with your aromatase inhibitor. This could be protective, and therefore, even if you take your breaks, the risk for developing breast cancer during or after pregnancy is limited. Are there studies relating to increased risk to cancer recurrence when tamoxifen is disrupted? No, none available. Yes, but your medical oncologist would be the best to explain these to you. If one gets pregnant and suddenly gets cancer, is targeted chemotherapy for pregnant women already available in the Philippines? I am not the expert to be able to answer this, but it would be best to consult. Remember, in your breast cancer treatment, you have not only your breast surgeon, but also your medical oncologist. I'm sorry, I have to emphasize, your medical oncologist will be your partner in your treatment process for your systemic therapies. They are in the best position. So it is in your part, it is best for you to be monitored regularly and take time to talk to them. Given the huge role of the lymphatic system in breast cancers, would you suggest lymph drainage as a preventive measure for cancer? I have yet to find out. Maybe it would be best to ask a breast surgeon. I am not an expert in breast cancer surgery. Okay, so maybe if we have a surgeon in the audience to talk about this, I would be more than willing to pick it up and take up his or her opinion about this as a preventive measure for cancer. Okay. Can can okay. Next, can tamoxifen alone can be used for a type 2 stage 2A breast cancer done right mastectomy? Rosario, I think you will need to discuss this with your medical oncologist because, as I have said, it all depends on your histologic grade, and you will need to determine the tumor panel tests together with your oncogenic genetic tests. So I assume because it's a breast cancer done with right mastectomy, can tamoxifen alone be used? Now, I think that was already the decision that was recommended to you by your medical oncologist. I think that would then be, then it would be best to pursue that recommendation. For young women, okay, next. For young women who will need ovarian stimulation later on for fertility induction, won't those hormonal medications aggravate the breast cancer? Studies have shown no. For those women that need ovarian stimulation, at that point, even prior to stimulating the ovaries for fertility induction, you would have already been treated hormonally by a certain period of time. And that would have already suppressed your the ovarian function in producing estrogen. And therefore, if we do and give you ovarian stimulation drugs, it will not aggravate the breast cancer at all. Hi po, Doktora. Pag matagal po ba gumamit ng contraceptive pills, posible bang magka-breast cancer po? Okay. Remember what I did say, okay? Taking pills could be a risk, but it will not be the cause of your breast cancer, okay? So, it is always best still, okay? Remember, it may increase the risk because of your ovarian stimulation with estrogen and progesterone. But remember, what are the risk factors? I did not put that as a risk factor that doesn't change. It's not part of the risk factors. But if in the event that you are fearful, remember, you still have control, Mitch. Pwede ka pa rin i-control mo yan. You do your breast examination monthly to determine if you have any lumps or any changes. Jaja, I am a survivor. Thanks be to God. Jaja. I am a survivor. Stage 3C, I've been through ups and downs. After mastectomy, removal of ovaries, and been depressed, I may say I am a warrior. Emotions is the toughest. I know God gave me a chance to live again. One thing that I may be missed by the doctors is referring me to a physical therapist, nutritionist, continuous exercises. malaki po ang hinina ng katawan ko. Lalo na po tinanggal ang hormone estrogen and progesterone na malaking advantage in helping our bodies lube. Just sharing. Thank you very much for sharing this, and we continue the fight. We continue to become the survivor. We just continue our prayers in faith, love, and hope. And yes, it is best to remember, okay, to see a nutritionist. As I did mention very briefly, your healthy diet, continuous exercise, you can do something about it. You can do something about it. Go ahead. There is a need to support. There is a need for that support. That's why if you have breast cancer, advocate, seek psychological groups. There are many out there. By the way, I would like to share that. We have the Philippine Breast Cancer Foundation. That is the only one that advocates breast cancer that's found in a public hospital. That is, I think, in East Avenue. And your Philippine Cancer Society, even the Philippine Society of Medical Oncologists, they have support groups. And maybe that is the best for you. And I hope and pray to God that you continue this fight. So if there are are there other questions? So if there are no other questions, I would like to thank all of you for joining me. This might have been a long lecture, but it is what it is. It's a long, tedious, process from the initial discovery to a challenging journey of diagnosis and treatment. Okay. There's a question that just popped up. If you have a breast lump, who do you go to? Your obstetrician gynecologist, or to a surgeon? Well, all obstetrician gynecologists see female patients. And the #1 risk factor for breast cancer is being female. And therefore, it is imperative that all obstetrician gynecologists follow up women with possible breast lumps. So remember what I said, breast lumps, don't panic. We may have lumpy breasts. It could be due to a benign disease from a hormonal from the hormones. So it is best to go through to your obstetrician gynecologist, and if there is a need there's a need for you to go, it is also best to go to a breast surgeon. You will be referred to a breast surgeon. But there are some women who would like to go straight to a surgeon. It does not matter. What matters is that you seek consultation once you feel a breast lump or you visually see changes in the breasts. Okay? So if there are no other questions, I bid you farewell, and I hope to see you again in my next lecture series on feminine wellness. Stay well, stay blessed, and let's continue this fight against breast cancer. Thank you. God bless us all.